We are now going to move on to our second patient panel of the day, where patients will share their perspective on the available treatments for the diseases, side effects, and how we can improve them. At this time, I would like to introduce you to our panelists. Janet Segal is the founder of the IPPF and Pemphigus vulgaris patient from Sacramento, California. Naomi Bishop is a bullous pemphigoid patient from New York, New York, and Doris Chenier is a mucous membrane pemphigoid patient from Baton Rouge, Louisiana. Our last panelist is Eric Schneider, is a bullous pemphigoid patient, and he's from Sugarloaf, Pennsylvania. Welcome to all of you. We're excited to hear your perspective on available treatments for our diseases, their treatment, their side effects, and how you think they can be improved. While I ask you these questions, we are again going to be polling our attendees with the same questions. This will help us give us an idea of their perspective on the topic as well. If you are an attendee who is not a patient, please do not answer these poll questions and just simply hit the exit to exit out of the poll. So at this time, we'll start with the first question. And Naomi, I'm going to direct this question to you. What are the most significant downsides to your current treatment regime? And how do they affect your daily life? And do you mind, Naomi, while we share the pictures that you had sent to us?
Not at all. Thank you.
Great.
So I, by way of introduction, have bullous pemphigoid, and I was diagnosed in November 2021. I'm fortunate enough to live in New York City, where we have several centers that actually are doing wonderful research and great treatments for patients. And so my course has been fairly smooth. After a difficult, I was first diagnosed with scabies and went through that whole routine, and then had the very difficult course that other people have defined on steroids, which were terrible for me. Since then, I was able to be started on dupilumab, and it has done a wonderful job at controlling my disease, at least for right now. It is not a panacea, certainly. It's a biologic, it's a shot. I have to be able to get it from a specialty pharmacy, and I have to reorder it every 2 weeks because they will not allow me to have more than that because it's a very expensive drug. So if I have a mishap with one of my doses, I'm then short and have to run around and find it. In addition, it has to be refrigerated, and so I have to be here when the drug is delivered in order to be able to receive it and get it into the refrigerator. It's a shot, so I have to dispose of the sharps. And true confession, I'm a former physician. I'm a physician, but now no longer practicing. In the hospital, disposing of sharps is very easy. It's not as simple out here in the community. And the other thing that's very difficult is traveling when you need to keep a medication cold, especially if you need to take a long airline flight. Just getting through security with shots and drugs is an interesting experience, but then keeping it cold and being able to take it when you need to take it can be very challenging if you're in the midst of a long trip. And so while I appreciate that it works really well, it comes with its own complications.
Great. Thank you, Naomi. Doris, would you like to share as well?
Sure. I'm sorry I didn't have pictures, but taking Rituxan, I sleep all day because of one of the pre-meds is Benadryl. So it makes me sleep all day. Let me start over. I was diagnosed with Pemphigus vulgaris in 2009, and I've been treated all these years past 13 years for Pemphigus vulgaris. Well, Becky and I went to a conference in September in Washington, D.C., and I had a major flare. And I was amongst dermatologists, and they suggested that a rheumatologist has been treating me, and they suggested that I see a dermatologist. And I came home and saw a dermatologist and found out that I actually have mucous membrane pemphigoid, because I've never had uh, the blisters or anything on my outer skin. I've only had it in the mucous membrane areas. I've had it in my mouth, my eyes, my vaginal area, my anus area, and it has been a roller coaster. And I'm still kind of emotional about it, because I just went to the doctor yesterday to start a whole new series of treatments. So I'm really kind of emotional today. But some of the other side effects that I have brain fog. I can't function on a daily basis for a week after I have Rituxan. Uh, I've been crying a lot. I've been dealing with depression. I'm really a very outgoing person. Like one of the people that said on the video, they gained weight. I was a very small lady, and I started out at 140 and now I weigh 190. I have mood changes, I have heart palpitations, I have depression, I have insomnia. I feel isolated. I'm no longer the outgoing, bubbly person. You know, my person, when I'm around people, my personality is generally outgoing. So because of the disease, I have tended to isolate myself. And I've also lost my marriage because I couldn't perform sexually. So that's some of the significant downsides for me.
Doris, thank you for sharing such personal aspects with us. Thank you. Eric, would you like to share as well?
The question is, what are my symptoms, or?
So what are the significant downsides of your current treatment, and how are they affecting your life?
Oh, okay. Well, I had all the different drugs, and including rituximab and Dupixent, and none of that really seemed to work for me. So I'm still on prednisone, but I'm on a very low dosage. I take about 5 to 6 milligrams a day. So I'm one of those lucky people, Mark, and this and how I feel about it. And one of the few people in this whole discussion had BP, Ingrid, who had 450 blisters on her body at one point. I didn't have that, and I've only had a couple of blisters. And in fact, bullous pemphigoid attacks the underlayer on your skin, so you can't necessarily be able to see it. You could be itching all over and only see red, simple signs. You don't even see bumps. So it's hard to measure that, I think, with this thing about how much damage you have to your skin. But for me, I've had it for 5 years. I've tried to avoid fatigue and being called elderly. Dr. Julie said that we were elderly. I'm only 78. So I'm not elderly yet, but I guess it is an elderly, BP is an elderly disease. But I seem to be having lots of other symptoms. This discussion about cataracts. I've had cataracts and operations in both of my eyes, and I had a blister, herpes blister on my eye about a month ago. And I'm beginning to think that maybe that was a bullous pemphigoid blister. And I'm concerned about that. And I've had a lot of neuropathy issues and joint issues and constant pain. I'm wearing this brace now, and it's either tendonitis or rheumatoid arthritis. So I have other autoimmune diseases besides bullous pemphigoid, and I didn't have them 5 years ago. And maybe it is that elderly business and old age. It's all getting to me a lot of other rheumatoid arthritis issues. But it seems to me that the research needs to look at all the autoimmune diseases that are attacking our body. And bullous pemphigoid may just be a symptom of the autoimmune system failure, as opposed to its own special disease, or maybe it's both. So yeah, I have all these things they've been talking about, and the high blood pressure, the nosebleeds. I never heard that one before. The neuropathy, migraines, pre-diabetic, all that stuff is happening. And I think it's all sort of related to the attack of our autoimmune system somehow.
Great. Thank you, everybody, for your candor in that answer. My next question, Janet, I'm going to start with you. What specific things do you look for in an ideal treatment for your condition?
Okay, so I believe that, well, I say hello to everybody. And say hello. I don't know if Dr. Worth and Dr. Morell are listening. I've known them for
Yeah.
decades, and I want to say hi to you guys. For me, treatment was only prednisone because I was diagnosed in 1983. I mean, 1983. It's been a long 40 years. And prednisone was the only thing available to me at the time. I couldn't get under 30 milligrams of prednisone without breaking up. And that was considered a mild disease. I couldn't even go to 28 milligrams without breaking out. And I mean, breaking out from head to toe and in my mouth and other areas. Anyway, so for me, anything other than steroids would be a acceptable treatment. I did get to go on Imuran when it became available, and that was in 1992 or 3, something like that. Well, I started the foundation around that time. And so Imuran was available, and I was on that with small dose of prednisone for several years. And it worked okay for me, and I was young. So I was diagnosed at 36, and 10 years later, I guess, off and on prednisone several times. And I had all the side effects that everybody talked about. I would like to see the FDA approve all of the drugs that we use right now sooner than 7 to 10 years, however long it takes. A lot of the drugs that when I took Imuran, it was off label because there were no clinical trials. Double-blind studies to me are not helpful for us because we don't get the drug, and you're going to get less people to get into the trial because of the worrisomeness about whether they're going to have to just be on prednisone or they're going to get the drug or Cellcept or Imuran or whatever else that they're going to, they did with the Rituxan study. And I want to see how that the doctors see that each person individually as the human, that some of them take more drugs than others. That there's not just one type for each person. Everybody has a different amount of drugs that they're good at. For me, it was 30 milligrams, couldn't get below it. And I was on 150 milligrams of Imuran for 5 years or so, however long that was. And then I had to go up to 200 in order to get rid of it. Now I have been in, I don't know if you call it complete remission because I have lesions that I get in my mouth from time to time with a little clobetasol makes it go away, like last night. But I basically have not been on drugs since 2002. So I've been a long time since I've been pretty clear. I really would like to see there be a less, I mean, I remember thalidomide trials, and that was part of what happened with the 7 years to get on a drug and all that kind of stuff. But with our diseases, our immune systems, I don't know, they seem to be working pretty well, except for our autoimmunity. I don't know if a lot of us get sick. I know I never really hardly got ever sick until I got pemphigus, and I never really got sick after I got pemphigus in terms of flus or cold. I got my cold every now and then. But anyway, I really would like to see not such a rigid standard that the FDA has for every disease that's out there and for all of the way the clinical trials are handled. So treatment would be, for me, the best drugs that don't give us the least amount of side effects.
Thanks, Janet. I think a lot in our community would agree with you. And also thank you for your tireless effort in advocating for the community and even starting the IPPF. Many of us truly have been appreciative of the support that you personally offer and the organization that you started. So thank you.
You're welcome.
And Eric, I'm going to ask you the same question to Janet. And while you do that, do you mind if we share some photos of you?
No, that's fine. No.
Great, thank you.
My answer is that I would take anything that's an improvement over what you have. For me, this whole thing has been about itching, because I've been lucky enough to not have the oozing, weeping blisters that other people have and all the other attacks. I feel lucky to have BP as opposed to vulgarians, to tell you the truth. But I think any step, ought to be, you know, the doctors have to be real careful about, you know, not giving us something like thalidomide. But beyond that, I think the 10% improvement, 5% improvement, sometimes a 2 or 3% improvement is enough, that there ought not to be a standout for a 50% improvement and that sort of thing. And maybe they didn't give enough of a test. I actually had Dupixent for 3.5 months, and it didn't seem to be working for me. My blood levels were a little wacky, so we decided to stop it. So I would say that anything that would make any person's life better is something they ought to try to do, you know, not at any cost, of course, I suppose, but, you know, they're taking so long and spending so much on the trials that maybe they could cut them down a little bit, shape them differently and make them happen faster and maybe more carefully with some patients, but not drag it out like they did with the Rituxan. Was it 10 or 11 years? And it's still not approved for BP. And I'm not sure it didn't work for me. Obviously it works for lots of people with BV. And I think if we talked about these things better, like Pemphigus Pemphigoid doesn't sound like it's all that bad. And Pemphigus Pemphigoid is just Greek and Latin for blister, I think. And I think that it'd be much more useful if they talked about oozing, weeping, itching, torturous disease or something like that. And people would know, you know, what we're talking about is not a joke. And I guess that's my opinion on that, Becky.
Yeah. Great points, Eric. Thank you for sharing. Naomi, what would you look for in an ideal treatment?
If you don't mind, I just would like to follow up on something that Janet said, which is I would love to see the FDA come up with a classification that for doctors that was a compassionate use for a drug, so that if a doctor felt strongly that that was the right drug to try next because of their expertise, they would be able to somehow get insurance approval for that. I know that that can happen sometimes with lots and lots of phone calls, but Medicare will not budge on drugs like mine because it's off-label. And so I would like to be able to see some category that can change that dynamic, because a lot of people who could benefit from certain drugs are not able to get them. And I think that's a problem. For me, the ideal drug obviously would be one that cured me, so that I wouldn't have to live every day wondering when the shoe was going to drop and I was going to go back into that horrible place. It would be a drug that I could take orally so that it would be simpler for me and I would not have to live my life around, am I here, am I there, is it time? I would like to be able to use my alarm clock again to wake me up for work instead of waking me up to take my medications. And that would be really good. And I definitely would want it to be a drug that didn't immunosuppress me, because that's one of my biggest fears in this world. You know, I think we all have some degree of PTSD from the whole pandemic. And then those of us who've been afflicted with this condition, I believe also have PTSD from it. I know that I was somebody who didn't know the word fear until this happened. And now it's a big part of my life and impacts every decision that I make.
Great. Thank you for being so honest and open with your answer, Doris.
An ideal treatment for me would also be something that I could take orally. The Rituximab takes a whole day away from me, and then the recouping period takes a whole week. So it's almost like a whole week of my life. It's like there are 4 weeks in a month, but I only get to live 3 weeks. The minimal side effects, the joint pain, the headaches, and the drugs that I've taken, because I was diagnosed in 2009, I've taken the Cellcept, the methotrexate. So my body has been through torture. I currently have prednisone-induced diabetes. I've had a heart attack. I've had a stroke, you know, and it's just all those things, the medicines that have caused the side effects. just something with minimal side effects. And I believe if I live in the South, and most dermatologists in the South are not familiar um, with pemphigus or pemphigoid. So I'm having a hard time with making sure that the doctors need more education so that they can participate in some of these trials and informational meetings so that they can understand exactly what we're going through. Like I told you, I just went to the doctor yesterday, and she's gonna have to call Mark, to learn more about pemphigoid, and it's just not fair.
Yes, Janet?
Yeah, I just wanted to add also that one of the things about a better treatment is the cost of the drugs. There are a lot of people who do not have the ability to pay their share of cost. When you have a $20,000 Rituxan treatment and you have to pay 5,000 or 2,000 or whatever. I mean, I'm a retire. I don't know what I would do. I would probably, if I had to go back on medication, I worry about it every day for 40 years. I wonder if it's coming back. So it's part of my life forever. And the cost to me right now, because I am I retired basically, except for a little work I do for the IPPF, and a share of cost is not easy for me if I had to go back. So I would consider going into a clinical trial just so that I wouldn't have to worry about all of the side effects. I mean, the cost side effects that I'd have to deal with. So cost is an issue also.
And I think, Janet, like in relation to your question, I mean, some of these cost issues are directly related to the fact that there aren't enough FDA approved therapies, right? So because there aren't enough tools in the toolbox or enough therapies or enough options, the costs, there's this cost burden on patients. And, that can be very significant.
This is, yeah.
Yeah, the other thing I was going to mention was, and Eric touched on this, is, the speed at which drugs are approved or developed and approved. And obviously we're seeing development ramping up and happening faster. And certainly FDA approvals are happening faster too. But we know just from experience with COVID and COVID vaccines that if we put our minds to it, we can get things approved much faster. And so we know that, speed is an issue, and we really need the FDA to be taking patient perspective into account and approving therapies faster so that we have the ability to have access to these therapies, and it doesn't affect the patient's costs and access to therapies, like you're saying.
I just want to say one more thing. If my disease reoccurs, I want to be able to go to my local doctor, doctor who's in a clinical trial right now, locally here, and say, I want the CAR T. I want that drug. And I want to be able to the FDA to say, I can have that drug, and I'll sign an NDA, or I'll sign something that says, I give you the permit, if anything happens to me, the hell with it. At least I got a chance to try this drug, and I want that ability to do that if I can. I want this drug available to me if I need it. That's what I want as a patient.
Great points, Janet. And I think this leads well into our next question. And I'll have you start it if you don't mind. And we've kind of alluded to it already. In a perfect world, therapies, excuse me, for these diseases would result in no lesion or disease activity so minimal, with minimal side effects of therapy. Unfortunately, we know that many of these therapies for pemphigus and pemphigoid do not achieve this ideal. So what would you consider an acceptable amount of disease activity a therapy should achieve for a drug to be approved?
Well, I have to say that for me, I get lesions from time to time in my mouth, depending on the foods. Chocolate, I remember Dr. Wirth talking about chocolate decades ago, and it was some patient who came in to see her. And some things will trigger a mouth lesion, and I can live with that. as long as it goes away, either by itself within a few hours, a day, or with a little clobetasol, I'm good. A lesion, here and there that'll heal. But the thing about pemphigus that's different than pemphigoid in some respects is that it will not stop once it starts. I mean, it really, if it doesn't clear up by itself, it's just going to keep getting worse because that is the disease. The disease for pemphigus vulgaris just gets worse. So how do you decide what is the best amount of disease activity that you can live with? Because for pemphigus, there is no best way to live with it unless, like I am, with occasional lesions that go away.
Great. Thank you. Naomi, what is your opinion?
For me, the ideal drug is the drug that keeps me out of the emergency room and out of my doctor's office for an acute visit, and lets me go about my daily activities. And I just wanted to make a comment about risk tolerance. I think what a lot of us have sort of shared today is that our risk tolerance for side effects is probably much higher than the people who are making decisions about drug approval. And that it would, I think, be great if that was taken into consideration. I still suffer from itch, and this is not an itch like when you get a mosquito bite. The itch of BP is a burning. It's like a lightning strike that sort of goes through your body. I can remember being in the shower and sort of flinching like a fish when the water hit my back. And that's a very different experience. And when it goes on all night and keeps you from sleeping, it's very, very difficult. And so for me, the ideal drug is something that prevents me from having that kind of experience again, but mainly is one that makes me feel like I'm a well person instead of a sick person, and hopefully something that I can get off of in time, that treats me enough to get me into a sustained remission that I may be able to stop in the future.
I think you just struck a strong chord with many of us in our community when you are describing that itch feeling and what you would hope a treatment would be like. Eric, what's your opinion?
I guess I already said it, that if you can stop the itching anyway, a little bit is better than none, but when the itching starts, it's just miserable. Steroids doesn't seem to do that, but I think it's given me a lot of other side effects, and I kind of like to get away from it completely. But as I said, a little bit of improvement is better than no improvement at all. And so, I don't think that there ought to be a limit, like it has to be 25% better than the previous treatment. It's got to be affordable somehow. But small tests of small people that they're authorized, say, okay, I want to hold you liable if I die from it. I'm willing to sign papers like that too.
Thanks, Eric. Doris?
For me, it would be not having any disease activity for a period of between 6 months to a year, because I feel like I always have activity from one time or another. From September to November, when I had my last dose of Rituxan, I had to stay on 20 milligrams of prednisone per day until I got the Rituxan. And now I haven't had any disease activity since November, but prior to that, every month I had to take prednisone for at least a week to not see any activity. So 6 months to a year would be good for me.
Great answers. Thank you for sharing with us. Our last question for the panel is, what factors do you consider when making decisions about selecting a course of treatment? And I will start with you, Naomi, for this question.
Okay, sorry, I have to check with my notes. The first would be, does it work? And if it works, how well? The next would be, are there side effects that I can find tolerable? And those would be basically ones, again, that let me go about my life without causing major disruption. Can I afford it? Is it practical and easy for me to take? Also, again, does it not immune suppress me? I mean, that for me, and I think for a lot of us, is a big deal right now, especially as the treatments that we have for COVID are working less and less. I think that has to really be a major priority, and looking at drugs like what I'm on that are minimally immune suppressive. That's
I think those are great points. Eric?
Oh, here's my dermatologist doesn't treat other DP people. As far as I know, I think she says she only had one other patient. And, if I don't complain about it, she's going to just let me continue to take the 4, 5, 6, 7 milligrams a day that I've taken. And I've been thinking about it and listening to all the session, if I should go back in and ask her if I should try Rituxan again with the IVG1 or whatever it was. But then somebody else said that was the drug that hurt them the most. So it's really, it's doctors have the knowledge. I really don't know how to treat me. I tell my wife, a nurse, all the time, well, don't do that, do this and all that. But in reality, I really don't know what I'm talking about, but I have a lot of opinions. I'm not sure that helps. I would listen to doctors, but I wish the doctors could be more aggressive, but they've got all kinds of limitations on them that affect anything they say to people like me. So how do they do that? I don't know. There ought to be something that, like somebody said about release and more a little smaller experiments maybe, or as I said before, I really think that the failure of the autoimmune system needs to be tracked down. Maybe that could be fixed. That's all I've got.
Thank you. Doris?
The things I consider are, what are the side effects? Because like I just said earlier, my body has taken a beating since I was diagnosed with pemphigus. I used to only go for well checks prior to that. How often the drug has to be administered, how is it being administered, whether it's IV or oral, and like Janet said, is it affordable?
Great. And Janet, I'll come to you and let you finish up this question. Then I'll give the doctors fair warning. As doctors taking care of patients like us, we're very interested in your opinion during this panel as well.
So unfortunately, there are not a lot of drugs available to us. We have prednisone, we have immunosuppressive drugs, we have the biologics right now. So really, there's IVIG, well, steroids, which will work pretty quickly, mostly if you have a high enough dose. And immunosuppressives, there's Celcept and Imuran. I don't even know if anybody gives Imuran anymore. It worked well for me, but and Rituxan and for pemphigus right now, there's for pemphigoid they have the Dupixent, I guess, is being used off label. So for me, considering a course of treatment, it would be anything where I didn't have to take steroids or be on a very low dose of steroids because it destroyed me. And now I'm older. When I was younger, it wasn't as well. Yeah, it was bad. I got all the side effects, all of them, including a very large amount of weight. And I definitely, at my age now, would not really want to be on steroids at all. And anything I could do to be off steroids, I would try again. But as I said before, we need to have these new drugs that are coming available to us. I'm 77 years old. 10 years, I'm going to be 80-something years old. And if I get a disease, if it comes back before then, I'd like to stay alive a little longer.
Great.
I have a comment on that. Yeah. Steroids was invented, I looked it up, in 1952 by a doctor. So that's what we're using today most of the time for this treatment.
Well, it works fast.
They ought to spend some money on something that would fix that problem.
Good point, Eric. Thank you. I think this is a good segue to hand it over to Dr. Morell and Dr. Wirth for their comments as well.
Well, I'll start. I really enjoyed hearing from the patients, and thank you so much for sharing these personal traumas that you've been through. Hopefully this is helpful to the FDA. I think we're stuck in a bind in that all diseases that go through approvals for treatments have this system of randomized controlled trial to prove whether a treatment is more effective than the existing treatment, with one exception, and that is cancer patients. If you've got cancer and you're going to die, they will allow you to have open label trials in many cases rather than randomized control trials. So I feel the pain of the patient when they say, oh, but if I go in a randomized control trial, I might end up on something that isn't effective. But I wanted to reassure the patients that this isn't happening. When we say placebo, they're still getting the dreaded steroid, which is what they would be stuck with if they weren't in a trial. It's not that they're on nothing. And I listened to the gentleman, Eric, and I agree with him about, even though he's so-called on a baby dose of steroids, he's having these long-term side effects from those steroids. And so even if the endpoint of a trial is to get someone on low doses of steroids like he is, he's still suffering from the long-term effects of these treatments. So we definitely have to have better treatments that can get our patients off steroids onto something else, even if it's an injection. I heard the thing about the inconvenience of the injections, true, and that you have to carry them on airplanes. But having treated hundreds of patients now with psoriasis over the last 2 decades who went from terrible treatments and tablets and methotrexate and now to a plethora of choices of these injections, some of which are only once every four times a year that they can be on and that they can give it themselves in their tummies, which is, I've had to have injections after operations every day to stop getting blood clots. It's amazing how you don't feel them when they're in the flab on your tummy compared to what you're thinking of a vaccine. You know, that's painful, that's into your muscle. So these injections, even children tolerate them. So I'm hopeful that we can get some convenient treatments that are self-administered at home. And I think the FDA is supportive of us, and we need to work better together to get our patients understanding that if they're in a trial, it will be a good thing for our community because it will help those patients and help all the future patients with these diseases.
Yeah, just one comment on what Dr. Morell is saying. And I think it's interesting because, and it really underscores the seriousness of these diseases, the immunosuppression of the treatments that we currently have, is that we're treating these diseases with cancer drugs. So in a lot of cases. And so, you know, that means that the drugs that we have aren't effective enough. And we need more options. So we need things like FcRn drugs and, you know, Bruton kinase inhibitors. We need these drugs because, you know, they're not cancer drugs, and we're not treating these diseases with cancer drugs. And so I think it's, you know, that really underscores the seriousness of the disease. And
I think, Mark, too, as our panelists throughout the day has pointed out, there is no one size fits all for our community. Some of us are eligible due to comorbidities to take some medications and not be able to take others. And some of us respond. You know, we wouldn't have these diseases if we colored inside the lines, right? So we're not always going to respond to it as doctors think that we should. So excellent points. Dr. Worth, I will have you have your comments.
Sure. I mean, there's been a lot of really good comments about how to select therapies and what people are, you know, afraid of. And I think with legitimate reason in this era, to be immunosuppressed is not great. And we should try to figure out ways of treating disease where we don't suppress the immune system to the same extent. So I think that's a really important to address that fear and that reality. I also think that in terms of determining what drug to take, it's really a partnership with patients, and it really depends a little bit on where they are in their life. If somebody wants to get pregnant, you might not want to be giving them rituximab, which would delay them being able to get pregnant. by a year. So, what works for one person may not work for another at this point. And so I think it's really important to individualize therapy. I think from the standpoint of the trials, we have a lot of room to go to try to improve what we do. I think we could use some innovative trial designs. I think it's hard for people to go into a trial where they're going to get a placebo. So having an open label extension where everybody can benefit from the drug is really a nice way of, I think, making sure that everybody benefits from being in the trial if the drug actually works. And I also think that we're not at a point right now where we have, like in psoriasis, the PASI 90, where people were or PASI 100, where people are getting clear. And so we have to have flexibility to be able to approve drugs that will work for the all the different problems that we're discussing, and maybe not going for clearance at this moment when we can't quite accomplish that. I think that the issues with rare disease trials is a really complex one because there are not as many patients. So we have to be really thoughtful about the endpoints that we choose. They have to be really validated and sensitive and what's meaningful to patients. And if we had tried to do a one-size-fits-all approach, I really fear we won't get the drugs we need. And in certain cases, companies will pivot to other diseases because it's just too hard if we don't really help them. Again, so we can have a reasonably sized trial with a validated endpoint. That will do a lot for us to advance the kinds of things that we're talking about today. So those are sort of my comments overall.
Yeah, thank you, Dr. Worth. And I think the resounding message, one of the resounding messages from today is that, some improvement is better, is what we really need now in the short term, with the long term being, complete remission. But due to how the disease, the history of the disease, it just doesn't work that way. As you said, we can't shoot for remission now. I mean, that should be the long-term goal, I think. And I think that's a really good message. I think we could go on all day with this panel, and I know we're over, and I really want to thank Naomi and Doris and Eric and Janet, and thank you, Dr. Worth and Dr. Morell, for your time on this panel. We really appreciate it, and appreciate you opening up and sharing your stories and sharing your perspective and your opinions, because Eric, it does matter. Your opinion does matter. And so it's important that we hear that. So before we open up the discussion to others that are listening today, I'm going to go ahead and launch another poll. And this is in regards to how the diseases affect your relationship and your relationship with your loved ones. So again, with the open comments, we ask you to limit your comments to those related to your perspectives on available treatments for the diseases, their side effects, and how to improve them. When we unmute you, please say your full name, where you're from, and the disease you have, and then give your comments. So let's go ahead and start today's open comments with Mindy Zimmerman, and Mindy is from Florida. Welcome, Mindy.
I thought it would be appropriate to have a beach behind me. It makes me feel good. Good afternoon. Thank you for your attention and for giving me as a patient the opportunity to talk to you today about my journey with my rare disease. My name is Mindy Zimmerman, and I was diagnosed with Pemphigus vulgaris, PV, after only one visit to my primary care doctor and a subsequent referral to a dermatologist. Starting in the fall of 2017, I experienced lesions on my scalp that would not heal. My hairdresser told me that she could no longer cut my hair because of the open wounds. Finally, I went to my primary care doctor early in April 2018 and was referred to a dermatologist soon thereafter. My first biopsy was for fungus and psoriasis, but after those results were negative, I mentioned to my dermatologist that I had some sores in my mouth. She quickly performed an immunofluorescent biopsy, and it was positive for PV. By the end of April, I was seeing a specialist in my area and had started treatment. This was before rituximab had been approved by the FDA, so I started with high-dose prednisone, high-dose mycophenolate, and doxycycline. Because I was on these medications, my doctor also prescribed Fosamax, omeprazole, calcium, vitamin C, and vitamin D, in addition to blood tests and regular bone density scans in order to lessen any possible long-term side effects. When I think back, I realize I went from being a person on no medications to needing a spreadsheet to keep track of all my medications and their doses. Can you imagine if I had severe disease? My disease activity became controlled, and I was able to lower my prednisone dose until I completely stopped taking it in May of 2019. I've continued on a smaller dose of mycophenolate and doxycycline, but today I'm still on a maintenance dose of mycophenolate. I've not been hospitalized or had any other infections due to any open wounds because of PV. I can also describe only mild side effects from my initial treatment: headaches, sleeplessness, weight gain, extreme moodiness. I call my side effects mild, but my house was never cleaner because I never slept. All my personal relationships were strained because of my lack of sleep, and I was extremely moody, jumpy, and reactive. I am immunocompromised because of my treatment, so I've changed my career path from teaching music full-time in the public schools to teaching only privately online. And since COVID, I've not been into school, and I won't be going back again. How exciting when the news came that the FDA approved rituximab for the treatment of PV in June of 2018. My doctor wants to get me off all medication, get me into long-term remission, and he knows that these infusions are the route to that outcome. I received my first infusion of rituximab in February 2022, utilizing the RA protocol that was studied in the Pemphigus study, which is 1,000 milligrams on day 1 and day 15. The anticipation of my blood work showing lower antibodies was just, I was so excited. Hopefully the desmoglein 3, the marker for PV, that was at the top of my list to have those numbers lowered. But my antibody numbers haven't changed. My doctor's plan is to get me into long-term remission, so the intention was to follow the same dosage in 6 months, as that has shown the best results in clinical trials. I know the focus here is only about side effects of the treatment. But even though the research has shown that 1,000 milligrams, I think we even saw that in one of the doctor's reports today, has shown that 1,000 milligrams on day 1 and day 15, and again, the same protocol in 6 months to be the best course to follow, my insurance only approved one treatment of 500 milligrams, for 6 months, and then again 12 months after the initial infusions. I just scheduled my appointment for February. My doctor's advice was to get the treatment I can and not fight with the insurance company. With my antibody levels remaining unchanged, this makes me think that I could have a flare at any minute. And stress can also lead to a flare. Again, I've had very little disease activity, have not had a flare, so I am in clinical remission, even though I am continuing to be on a low dose of mycophenolate. So I wonder if I might be on mycophenolate for the rest of my life, because even with the rituximab that I've gotten, my disease has basically stayed the same. Hopefully, in my speaking to you today, I've not gone off topic too much. Let me thank those of you who do the work to make sure new treatments get approved by the FDA. So today, most PV patients don't need to take prednisone for a prolonged amount of time. As a better frontline treatment with fewer side effects, rituximab infusions are available today. As more patients are being treated with rituximab, hopefully, other than infusion site reactions, there will continue to be statistically very few other side effects. And let me thank everyone who's listening today and all the people who organized this. Thank you all, and appreciate your time.
Thank you, Mindy. I think there's quite a few things in your story that you shared with us today that were striking, from being on zero medication to needing a spreadsheet and hanging your hopes on a medication that would make your numbers go down, and realizing that despite being on numerous treatments, you're still at the same place that you were. So thank you for sharing your story. At this time, we're going to hear from Arthur Gelber from New Jersey. Arthur? I think you might be on mute, Arthur.
Okay, I'm
Yep,
here.
we can hear you.
Okay, well, I don't know how good it would be for the listeners, but I was able to get myself unmuted. And I thank you for the opportunity to vent my tribulations and dealings with bullous pemphigoid. It's there's optimism for potential medical treatment, which really keeps me enthused about these types of meetings and the idea to learn more about the ailment and the possibility of a cure. If I know I'm using the word loosely, but what I'm looking for is a cure. I'll grant a remission. Uh, 2 years ago, after getting my first COVID-19 vaccination, I began getting blisters all over my body, similar to blisters that prior presenters have described and shown in pictures. Ultimately, a biopsy led to a diagnosis of bullous pemphigoid. Um, since then, I've been on a quest to find the holy grail of a quick and long-lasting effective treatment. The restrictions on my life's activities were enormous. To start repeating them, I would sound like a tape recorder, repeating everything that prior people had to say about their unfortunate experiences. Whether or not COVID-19 vaccine was the cause or the trigger of the blisters is not the issue. But since starting on my quest, I have learned that there are several possible triggers for BP. It often occurs at an advanced stage. I prefer that term instead of calling it elderly. And stress may be the aggravating factor. However, I have also learned that many dermatologists are not familiar with BP and its cousins and its possible treatments. Prednisone is the drug most often used, but that has serious side effects. After strong resistance on my part against prednisone, I was prescribed Cellcept. That has the potential to lower hemoglobin levels. And even though I was constantly monitored after my first COVID booster, I wound up in the hospital in critical condition. I thankfully recuperated after my hematologist suggested that I stop using the drug. Thank you, Janet, for your activism and founding the IPPS. Fortunately, through the organization, I have learned a lot about BP and the extensive research being conducted concerning it. Unfortunately, I found the rare dermatologist extremely knowledgeable about BP and its treatment, and she prescribed Dupixent to help concerning BP and my psoriasis that and they appear to have been mitigated by use of the drug. There are some prescription medications in the pipeline that may possibly be effective in the treatment of BP. News about those medications needs to be spread throughout the medical profession. Others have said that here today, and I just emphasize it. I urge the FDA to accelerate testing and the release of those medications to help improve the lives of people with this debilitating autoimmune condition. The FDA was able to release in 1955 the polio vaccine after many, many, many years of research. The amount of time for determining the efficacy and safety of drugs has reduced somewhat, but not enough. The FDA should be able to accomplish the release of effective BP medication more quickly with modern technology and research, a theme that seems to be running through all of the presentations raised this afternoon. Thank you very much.
Arthur, thank you. And that was very eloquently put. I really appreciate your comment. Next up, we have Sharon Radke from Vermont. And Sharon, you can go ahead and turn your camera on and your mic on and provide your comment. You're on mute.
Hello. Hi, everyone. I've really enjoyed today's gathering. It's just been it's so nice to see people that have faced many of the same things I have. And it just, and that's one of the things I'll be talking about today is that I live in Vermont. It's a small state. There's only 625,000 people here. We have one large hospital and a bunch of little hospitals. So blistering disease specialists are not to be found here. So I was diagnosed with Pemphigus vulgaris in 2015, but I was lucky that my dermatologist had trained at Johns Hopkins and knew what it looked like. So within a couple of months, they had figured out what I had, and she started me on the treatment regimen. It took me 5 years to reach remission. But even now, I still get sores in my mouth from time to time, which I treat with clobetasol gel. My treatment included high doses of prednisone, 80 milligrams, and I tapered down slowly over 11 months. I also took Cellcept, 2,000 milligrams a day for 5 years, and I had 8 rituximab infusions. In the end, I believe the rituximab is what healed me. Now, Cellcept, I never really had any side effects to that until almost the end. And just before I went on, when I was at the end of just before remission, I took Cellcept briefly this summer, and I had a little relapse during my relapse, and it bothered my stomach. So I'm not sure if I could take it again, but it did work for 5 years. And then rituximab, I really never had any reactions after the treatments, but during the treatments, it was always a little bit shaky each time because I would always have some kind of reaction, and then they'd have to give me more meds, and then I'd have to wait an hour. And they also found by having the drip slower, it helped, but it always took like 7 hours. So it was a good part of the day. But prednisone, even today, I don't think I could put a prednisone pill in my mouth and swallow it. I just had a terrible experience with it. I dealt with moon face and insomnia, depression, crankiness. However, once I began to taper, the side effects got 10 times worse. I had terrible muscle pain in my legs, so much so I had to use a cane to walk for 6 months. I went to PT for a year. And I finally felt better, but it was 6 months after I had gone off the prednisone. Pemphigus and the treatments changed my life. I had been an event and marketing specialist for 30 years, and I taught at a local college. I taught in event management. Due to PV and the treatments, I could no longer work those long days, and I stepped down from my teaching position. And during my very last 2-day event, my husband had to push me around in a wheelchair because I couldn't walk. Rare disease in a rural state is very, very challenging. We have no blistering disease specialists here, so I was lucky to find the dermatologist who understands PV. And for a time during the pandemic, I was able to receive treatment from the blistering disease specialist at the University of Pennsylvania via televisits. Dr. Corey Simpson helped me every step of the way to reach remission in August 2020. Unfortunately, I can no longer access this treatment because the laws changed after the pandemic, and I cannot receive medical treatment across state lines unless I travel there in person, which would be very difficult for me to do physically and financially. You know, it was a huge relief when I reached remission after 5 years. But others had warned me that those who have autoimmune disease often face a second autoimmune disease or health condition. So I was shocked when it happened to me. Since remission, I have developed a condition where my body overreacts to many, many foods, medications, and even scents. Symptoms include erratic blood pressure that causes fainting, severe intestinal pain, and anxiety. If I eat the wrong food, I pass out. It's very scary. I'm now being treated with antihistamines and a special diet by my primary care doctor for what is suspected to be mast cell related issues. And again, there's no specialist here in Vermont. I think the closest is in like Tarrytown, New York. My biggest fear right now is that I will have a pemphigus relapse, and when they try to treat me with Cellcept and rituximab, that my body will reject both, and then what? Having a rare disease is very, very challenging, but honestly, the side effects can be equally as challenging. It is a very lonely place to be. I could not have dealt with all of this without the help of the Pemphigus and Pemphigoid Foundation and my online Pemphigus support group. There's only like 4 people in the whole state of Vermont dealing with pemphigus, so it's nice to see somebody else. You all helped me through my journey. It's just been, I don't know what I'd do without you. What we really need are treatment coaches to help us deal with the treatments and their side effects. We are all PD warriors. Thank you for letting me share my story.
Thank you, Sharon. I think you highlight some very important parts of the patient's journey that even though we live in a very medically advanced country, it can still be very hard to find treatments. And your story really highlights the side effects that patients have and in dealing with changing your lifestyle and dealing with medication. So thank you for being so candid and sharing that with us as well.
Thank you.
Next, we're going to hear from Lori Speckler from New Jersey. Oh, you're muted still.
And there's the mute. Okay. So hi, my name is Lori Speckler, and I have to say I'm a little overwhelmed by listening to everybody's stories, how much they're the same and how many differences and how lucky I was. So I live in Closter, New Jersey, and I was diagnosed with Pemphigus vulgaris in July of 2018. In that one phone call, I went from being a healthy person who took the occasional aspirin like Mindy to someone who needed access to life-saving drugs. After months of being misdiagnosed by a variety of doctors, it was finally my dermatologist who took one look at the lesions on my back and asked if I had anything going on in my mouth, which of course I did. So I said yes. And she then took a biopsy of a very active lesion that was under my arm. It took another few days to get the results. When she called me with the diagnosis of PV, she also told me not to look on the internet, but of course I had to, and it was terrifying. So when she told me that I needed to start taking 60 milligrams of prednisone, I couldn't wait to get started. I gladly took the pills and used clobetasol steroid cream on my skin and mouth lesions as well. I knew prednisone would save my life or could save my life, but I soon also learned how debilitating it can be. I couldn't sleep, I was agitated. And then my dermatologist sent me to an endocrinologist who put me on another drug, raloxifene, to prevent bone loss. I didn't experience the weight gain so many people do on steroids because I couldn't really eat. So many foods hurt my mouth, including anything spicy, anything crunchy, anything with preservatives or acidic like orange juice. I still can't eat apples. And alcohol was and still is something that is occasionally a trigger for oral lesions. So I avoid it. Not a teetotaler, but I can't drink a lot. After a few months on steroids, I was still getting new lesions. So my dermatologist added an immunosuppressant, mycophenolate mofetil or Cellcept, which made me sleepy and couldn't be taken with food, but the steroids required an antacid and had to be taken with food, which meant all day I was watching the clock to plan out my medications around my meals and my medications. But while the steroids seemed to be helping, The immunosuppressants only seem to be making me tired. So my dermatologist started talking about Rituxan, but at that point, the possibility of an infusion scared me and she didn't push it. I just didn't have enough information to make an informed decision. I also went back to the dentist who months before had misdiagnosed my initial sores as aphthous ulcers. I might have switched dentists, but I couldn't find one that was familiar with Pemphigus vulgaris. So we got educated together. She suggested I go to a periodontist to treat my inflamed gums and increased tartar buildup. Finding an oral surgeon familiar with pemphigus proved impossible in New Jersey, so I went into New York City. The treatments required extra time, extra medications to numb my gums, and lots of extra money because none of this was covered by my insurance company. Along with a lecture on how to brush my teeth, I was prescribed yet another topical steroid for my gums, triamcinolone, and told that I would need extra visits to the dentist each year. Before pemphigus, I was a star dental patient for someone my age. Now I was in New York City in a dental office with 90-year-olds being criticized for not brushing my teeth properly. So at this point, I'm taking steroids, I'm putting steroid cream on my lesions and in my mouth, and things are improving, but I was still experiencing new outbreaks and still having difficulty eating and brushing my teeth. In the fall of 2018, I went to a conference held by the International Pemphigus and Pemphigoid Foundation. It was this conference that I was given the knowledge and power to make the decision to get started on Rituxan. At this conference, I also found a New York City dermatologist well-versed in Pemphigus vulgaris and the latest research. I was told about magic mouthwash, which can be made with a variety of ingredients and can be found on the internet. I was given soft toothbrushes that didn't hurt my gums and non-steroidal anti-itch cream, and I was given hope. Between 2018 and 19, I received a total of 4 Rituxan infusions prescribed by my new dermatologist, 2 rounds of 500 milligram IV 2 weeks apart, all of which caused fatigue and hair loss. I had allergic reactions during each infusion, including hives and rashes. One time, the hives and itching were so bad that they had to stop the infusion in the middle. They stopped and threw out half of a single infusion that was billed at $89,000. During another round, I wasn't given the extra steroids before the infusion as prescribed. The next day, I couldn't get out of bed because my joints hurt so much. I couldn't walk for 2 days. My dermatologist was furious that her directions hadn't been followed, but she was in New York City and I was in New Jersey, and my insurance wouldn't pay for me to get the infusion in a New York City hospital. Now I have a handwritten list of directions for any future infusions. High dose of prednisone the day before with Zyrtec, which someone today said is a problem. IV drip of Benadryl, Tylenol, Solomedrol, and Pepcid the day of the infusion. It's a lot of drugs, and after the infusion, it takes me about 6 months to feel completely normal. I now know that a 4-dose protocol with a lower dose each time is being studied for efficacy. I think I might have done better on lower doses administered over 4 weeks instead of 2. But speaking with medical professionals, I'm told that it is a fight with the insurance companies to bring patients into an infusion center 4 times instead of 2. But it seems like the outcomes could be better and safer. Today, I am in remission, but I also have dental and gum issues I never had before. I've recently been diagnosed with osteoporosis, and I can no longer do field work in my local nature center where I've volunteered for decades because I was told to avoid poison ivy. What is the long-term impact of Rituxan? Nobody seems to be able to tell me with any certainty. But for now, I am one of the lucky ones. I am not in debt from the thousands and thousands of dollars in additional medical and dental bills. I consider the timing of my diagnosis as very lucky. 1 month after the FDA approved rituximab for PV, the first new drug for pemphigus in over 50 years. I finished Rituxan treatments before the pandemic began. And to echo what some said earlier, I have a supportive partner, which was and is so important. What do I wish for? Until there is something better, we need to push for Rituxan first before steroids. We need the best infusion protocol for patient outcomes. We need more drug options specifically targeting our disease. And we need better dental protocols and drugs for our gums and tongues and mouthwashes and cleaning protocols. We need the information online and available to all dermatologists and dentists. Thank you.
Lori, thank you so much for your very emotional comments. I appreciate it. And what I love about your comments were you really highlighted the importance of shared decision-making between patients and doctors. That I think was very, very important, but also really highlighting the pitfalls of treatments, available treatments, and also the access challenges that you and so many patients with these diseases have when just trying to feel better every day. So thank you so much. Our next speaker, our next comment is coming from Joel Savat, and Joel is from Texas. And Joel, thank you for joining us today. I know you have some pictures that you said we could share. So if it's all right with you, I'm going to go ahead and share those pictures while you provide your comment.
Great, thank you. Good afternoon. My name is Joel Sabat. I'm a general internist, researcher in medical decision-making and patient-reported outcomes, and person with Pemphigus vulgaris. I was first diagnosed in 2019. I received 2 cycles, a total of 3 infusions of rituximab, which put me into remission. I did well until I had a flare early last year. Besides blisters on my back, waist, and thighs, my main symptoms this time were blisters and erosions on my head. The blisters and erosions on my scalp and behind my ears prevented me from wearing masks, one of the few defenses we have against COVID, for more than a few minutes at a time. The blisters and erosions were painful, and instead of healing normally, they turned into thick crusts. The scalp crusts were not only unsightly, but they prevented me from wearing a hat and sunglasses, which are necessary to protect against the sun in Texas. So you see a picture of my ear showing the skin breakdown behind my ear and the thick crust in front of my ear. These came about from wearing tight masks such as N95s and KN95s. And you see a picture of my scalp from late last summer. As you can imagine, this made it difficult to go out in public. As I mentioned, I responded well to rituximab in 2019, but that was in the pre-COVID era. When my pemphigus flared a year ago, I hesitated to get another round of rituximab because multiple studies have shown that it's the single riskiest immunotherapy drug anyone can be on during COVID. By depleting your B cells, rituximab greatly inhibits your ability to respond to COVID vaccines and puts you at greater risk of severe disease if you get COVID. So instead, I tried to manage with just topical steroids and then prednisone, but things eventually got so bad that rituximab became the only option. So I did get 2 more infusions of rituximab plus a long steroid taper, and we'll need another infusion later this week. My normal schedule would involve interacting with patients, having a lot of research-related meetings, and traveling frequently. But I've had to avoid almost all of that and all indoor social and recreational activities while on rituximab because of the risk of COVID, flu, and RSV. Rituximab is an effective treatment, but it is certainly a double-edged sword. Importantly, it takes several months to start working, during which one often needs to take prednisone, which, with its numerous and potentially severe side effects, is another double-edged sword. Pemphigus and its treatment then have had major impacts on my quality of life, stemming from first, the direct impact of pemphigus, namely painful and unsightly skin lesions and the inability to wear a mask. And second, the indirect effect of treatment with rituximab, which depleted my B cells at a very precarious moment in time, the tripledemic of COVID, influenza, and RSV. My message to the committee is that we need better medications that work faster and target just anti-desmoglein antibodies. I also strongly believe that more patient-reported outcomes studies assessing both health status and health utilities are needed to explore the full impact of pemphigus and treatment of pemphigus. Thank you for the opportunity to speak before the committee.
Thank you, Joel. I think your story highlights truly the impact on the quality of your life that the disease has, but the decision tree on which treatment is best, especially in our current times and our current disease climate. So thank you so much for sharing your story today. Next, we are going to hear from Rebecca Oling from New York.
Hear me okay?
We can.
Awesome. Hi. So my name is Rebecca Oling. I was diagnosed with Pemphigus vulgaris while I was pregnant with my second child at the age of 35. Suddenly, a 13-month-long mystery of painful sores that didn't heal suddenly made sense. And even though it was a harsh diagnosis to get, it was a relief to know it was not something I made up, that it was real, and that it had a name, and that I could begin to think about treatments and how we were going to attack this. Despite that long diagnostic journey, I now had to embark on a years-long treatment journey that was full of more pain and struggle and consequences. After failing several treatments, including a long stint on high doses of prednisone and one hospitalization in which my throat was so rife with lesions that I could not swallow, and the steroids had to be infused, I began to pursue Rituxan. At the time, 2008, the drug was not approved, as we've heard, for pemphigus, and it was a very long battle with the insurance company to get approval for the off-label use. The red tape and bureaucracy of the time and the waste was really outlandish. The insurance company didn't find pemphigus studies on rituximab to be statistically significant because, as a rare disease, studies at the time had success in maybe 9 out of 11 patients. I had to fail several other treatments first. They call it a failure ladder for a reason. So I did. I used topicals like clobetasol and triamcinolone, which we've heard about, magic mouthwash, and the rest, but those barely touched the surface of the issue. The prednisone, as Janet had warned me very early on, was like a train out of the pemphigus was like a train out of the station, and was beginning to really impact my life in a way that became unbearable. The prednisone made me a mess in every area of my life and had immediate impacts on my bone health. I did a baseline before I started treatment, and so it was clear to see that I had lost 11% density in my spine within the first 6 months of using steroids. Tapering off prednisone was also a nightmare, and the way I tapered had to be carefully monitored. Unlike most people who taper by milligrams, again, I'm rare, I had to keep a steady taper by percentage as opposed to milligram, and no medical professional wanted to play that game. As far as they were concerned, we can't do the math. And even though I do hate math, it's true. When your life is at stake, you do the math and you figure out the numbers. And so we did. That was the only way I could taper. I had also done CellCept, and the CellCept didn't reduce the lesions at all, and was extremely difficult for me to tolerate. As one of the other speakers said, you have to take that, you have to sort of map out your day and figure out when you're going to take what, and you have to take that on an empty stomach and stay on an empty stomach. And it made me so nauseous that the only way that I could do this was by waking up every morning at 3 a.m. to take my pills so that maybe I could sleep through some of the nausea. Eventually, after failing all these treatments, I was finally approved for rituximab and IVIG. And I know this isn't really about the insurance industry, but I live in the New York metro area. And, there was some suggestion that they would send me with a caretaker down to like Maryland to a cancer center of excellence. I live in the New York metro area, so this was not doable for me, especially with small children. Rituxan did eventually get, I was able to get it, and it was very difficult once I got the approval to get somebody who would infuse it for me. So as you can tell by my story, I already had 2 young children and a job, and I was trying to keep my life going, and losing an entire day going into the city would prove difficult, especially if I was going to maintain any of my other responsibilities. So I basically was able to find an oncologist who would be willing to do it. No other doctor around here would take care of that at all. In fact, all of the rheumatologists who had used rituximab for RA had washed their hands of it because the protocol, even though it was very much the same, they were just unsure of how to deal with a Pemphigus vulgaris patient. Again, in the New York metro area. And, rituximab is not a magic bullet. It takes time. We're rare disease patients and, none of us are alike. No one knows how long it's going to take to affect an individual and show some kind of efficacy or not. You don't know if you're going to have that. It could be another failure for me. So each individual is different. I happen to be the rare disease patient who also scored the rare side effects of migraines to rituximab. So every time I have to take rituximab, I have to prepare my life to lose 3 months to daily migraines. And that obviously makes life difficult. You can't, there's no basketball games, there's no, school plays, there's a lot you can't do. So I hear Lori when you get choked up because I feel the same way. You just want to be, a productive individual. Of course, the rituximab worked for me and I would 100% do it again because it's all I have. But that's the problem. And that's why we're here talking today. We need more treatments with less red tape so that those of us who are already felled by side effects, and who may lack coverage have some choices that allow us to be productive members of our society. There's a stereotype of rare disease patients. I'm probably meaning some of that now talking about my woes, right? But the truth is that a lot of the barriers that we face are barriers that are societally induced, right? If we know that there are treatments out there that could be efficacious for us, we should be able to, as I think it was Janet said, sign something and say I'm willing to take that risk because I already know the risks of prednisone and some of the other drugs that I've been on. Even though I've gone into a fairly stable remission, I do get flares occasionally, and I've been able to handle those with the topicals and with intralesional injections. I haven't heard anybody talking about intralesional injections, but let me say that again. Intralesional injections, this means that for me, I have to get multiple injections around the site of the lesion. And my lesions are always in my mouth and often in my throat. As you heard, that's what put me in the hospital. So just imagine 6 to 12 shots in the back of your throat. And don't scream because your toddler is next to you. You don't want to scare them about going to the doctor. So often when I would get my shots, I would sing really loudly. And I can't imagine what people in the other room thought as I was getting my shots. Could you even do it without gagging or screaming? It's a lot. So Rituxan is my answer for now, but it had a long-lasting effect on me that I couldn't have foreseen at the time, the deal I was striking with the devil that I had no idea was coming, and that was COVID. So it's forever changed my body's ability to handle the COVID vaccination. When the boosters first came out and we were told that the first round of people would be those who are immunocompromised, I was like, am I immunocompromised? Because it's been almost a decade since I did my rituximab. And sure enough, I went back to my oncologist and I said, listen, I don't want to take this from somebody else. Am I immunocompromised or not? Am I holding the vaccine? So as opposed to an antibody test, he did some kind of spike protein test. And sure enough, it was clear that my body just doesn't hold the vaccine the way it's supposed to. So they don't last as long for me, which means I have to curtail a lot of my daily activities. And I'm, one of the few people who's always masked at every event. And Zoom is probably the only place that anybody sees me smile widely. And that has an impact on your life as well, especially right now. So my life during the pandemic has been scaled back to only those gatherings or meetings that are most essential to my life or to my work. Doctors' visits, unavoidable work meetings or presentations. My son's varsity basketball games, well, that's a deal, right? Like, it depends. Is it a place where there's going to be ventilation? Is everybody going to be stuffed in there? Homecoming? Can't do that. You have to do maybe a lesser game where, it's not going to be as crowded. And most high school gyms have no ventilation, as you can imagine. Most parents don't need to think about that stuff. And I certainly do. But despite the rituximab's effect on my ability to ward off the plague, I'm prepared to do it again in a heartbeat if a flare becomes more frequent or intransigent. And that's full well knowing that I'll have to pay with 3 months of migraines. Rituxan, was 100% worth it for me, even with the lasting effect on my immune system, because I get those other 9 months of the year. But what if there was something better for me that didn't result in migraines and didn't have a disabling, compromising effect on my system? What if that treatment wasn't such a struggle to get? We need more treatments, and we also need the approvals to go much faster than they do, allowing for off-label use of promising treatments without having to endure the failure ladder. Because when I fail, my family fails. And when I fail, everybody in my circle fails, right? Like I fail at work, I fail everywhere I go because I can't manage. And what if days and months hadn't been lost to me and my family? Where would that be now? Rare disease patients already have a lot to face. Just understanding where they are and having to drag every single practitioner along that journey like some kind of rare disease Sherpa, losing time with family and work and failing treatment after treatment and waiting endlessly for approvals that come so late that it should just be a thing of our past. And we see this now with COVID. We were able to push approvals along and do the emergency use. We should be able to have some of those. I know it's not exactly the same because it's not a public health emergency, but we should be able to have some mechanism by which we can take control of our lives. Yesterday, true fact, I was told that I have steroid-fed cataracts and will need surgery probably later this year. I'm 54. While younger people do develop cataracts, according to my doctor, they are often not aggressive and allow for a more wait-and-see approach. Years of steroids have hastened this growth. The average age for cataract surgery in the US is 73. More treatment options, fewer side effects, and please get us off the failure ladder. It's named that way for a reason. Thank you.
Thank you, Rebecca. Thank you for sharing your story and really, talking about the delay in the treatments and how they caused additional pain and suffering for you and your family.
Yes.
And also really, making sure that, I liked your point about, we don't need a magic bullet, right? We need something that just makes us feel better and helps us just live a normal life. So, thank you so much for your comments.
Thank you. And I don't expect perfect, just better, right? Thank you.
Exactly. Next up, we have Mark Friedman from Florida. And Mark, I know you sent us some pictures. I can bring them up here.
Sure, go right ahead.
So, please share your story, and we're going to show your pictures.
Just wanted to make an impact to show you how debilitating this disease can be. My name is Mark Friedman. I'm 73 years old, first diagnosed in 2011, Pemphigus vulgaris and foliaceus. I've had many years of out-of-control flares, hospitalizations, therapies, pain, and discomfort. My initial pemphigus flare resulted in scabs and sores, raw skin over 40% of my body. I was initially treated in a burn unit in Tampa Bay Hospital and debrided, scrubbed, a practice no longer done. That amount of pain is incomprehensible, and no amount of pain drug can protect you from the horror of it. As others, I have had endless infusions, IVIG, steroids, and rituximab. I was very fortunate that a well-known doctor, Dr. George Cohn, worked at University of South Florida at Tampa General Hospital. He had extensive knowledge in 2011 of pemphigus and had worked on many people with it. I vividly remember him walking into my room. I was raw-skinned, did not know what I had, and in tremendous pain. He looked at me and said, "I know what you have. I'm going to fix you up, and you're going to be okay." Wow, what an impact that was. Now, I've been fortunate that I had a good diagnosis early on. After 1 week of round-the-clock infusions, I was sent home. A hospital is a dangerous place for you to be. 9 months later, after leaving my skin and bleeding on everything in my house that I touched, sat, or laid upon, and with a lot of new skin, I was able to resume my daily life Sort of. Pemphigus can be, if left untreated, a horrible, debilitating disease and even fatal. Therapies can improve your condition and save your life, but they do not bring you back to 100% health. They only work and help you become functional. The symptoms, as everyone has said earlier today, you can't lead much of a life. Flares are painful. Sleep is impossible. Fear that the symptoms are not going to end. No patience, anxiety, depression, and helplessness. Repeated flares can leave one mentally defeated. Nutrition and eating can become a serious problem. No desire to be in pain from eating. One cannot possibly work, creating possible financial distress. Brain fog, the simplest of tasks, become hard and slow. Impossible to socialize, open sores. Mobility from open sores becomes a problem. Sitting in a car, riding in a bus, even sitting or walking in a mild breeze can be extremely painful. Wearing clothes on your raw body. I wore a sarong bottom and a t-shirt top with no sleeves, split down the middle just to get it on. Thankfully, there's a lot of information available today and a better level of awareness to help deal with pemphigus. In addition, general practitioners, dentists, immunologists, and ENTs are more helpful with early detection. Available treatments that everyone's gone over, prednisone, Celsep, methotrexate, and many others, all have horrendous side effects: fever, chills, headache, weight loss, blood in the urine, stomach pain, swelling, and many, many more. Topical creams and gels such as triamcinolone and clobetasol are somewhat helpful in recovery. The therapies all help, and you become more functional and heal to a degree. Treatments and results differ from person to person. They are not a cure. For me, rituximab and its biosimilars work best, reducing my CD inflammatory response. I get infusions every 2 years. I take no Celsep and no prednisone. I have most recently had esophageal pemphigus, very painful, very hard to diagnose. So I still have my flares. How to improve? In a perfect world at this time, in my mind, rituximab or a biosimilar easily delivered into the system. Perhaps a low dosage, pre-dosed injectable pen administered at home or in an easy environment over a longer period of time could be very helpful to pemphigus people. Also, when you flare, access to drugs in a timely manner so that your condition doesn't degrade as you're waiting for an insurance company to approve you. Approval of orphan drugs for pemphigus people. And in closing, instead of one drug for one disease approach, one drug for many diseases is a new approach. As Janet said, when we're older people, all we can worry about is that we're going to flare and how we're going to possibly be able to pay for it. Thank you.
Wow, what a powerful story, Mark. Thank you for sharing your story and sharing your thoughts with us today.
Thank you.
I really appreciate it. We all really do. Next, we are going to hear from Robert Schwartz from Michigan.
Hello, can you hear me? Can you see me?
Yeah.
All right, thanks for sticking around. My name is Robert Schwartz and I live in Grand Rapids, Michigan. I was diagnosed with Pemphigus vulgaris in September 2020. I was treated with steroids, rituximab, minocycline, and niacinamide. These drugs worked for me. My skin healed and I could eat again without pain. These were not minor improvements, but rather potentially life-saving interventions. However, these treatments exacted a terrible toll on my physical and mental health. Taking prednisone was one of the worst experiences of my life. There were days when I wondered if taking steroids was worth it. A couple of times, being dead seemed like a reasonable alternative. The side effects, you've heard about all of them today: high blood pressure, repeated bouts of thrush, intense GI pain, weight gain, acne, blurred vision, and difficulty sleeping. That was bad, but the psychological toll was worse. Those symptoms included irritability, feelings of helplessness, and manic behavior. I was a jerk for about 6 months, and I'm lucky to have an understanding spouse and tolerant coworkers. Mark kind of stole my joke here, but a pharmacist friend of mine put prednisone in perspective this way. He said, everyone knows how bad cancer drugs are. That's common knowledge. But steroids are so bad, they give you cancer drugs to get you off the steroids. Between the pills for pemphigus and the pills to manage the side effects of prednisone, I was taking 15 to 20 pills throughout the day. Some mornings it took a lot of willpower to take that first fistful of pills. Additionally, there were oral gels, rinses, and lozenges, all of which had to be juggled to not interfere with each other. I also spent as much as 90 minutes per day doing twice daily dressing changes on my back and armpits. You can't put ointments and dressings on your own back. Therefore, my spouse had to help. So wound care was also time consuming for her. Outside of academic medicine, most dermatologists have treated few, if any, pemphigus patients. My first doctor started me on too low a dose of prednisone and tapered me too quickly. When my disease was not being controlled, I despaired about whether my doctor was knowledgeable enough and if I would ever get the right treatment. After educating myself, I advocated for myself and eventually got the correct dosage. After more self-advocacy, I also got rituximab. However, these delays and missteps caused me to be on prednisone about 4 to 6 weeks longer than necessary. I work in hospital administration, and I was responsible for providing COVID vaccines to our workforce. My first round of rituximab was about a month before vaccines became available to healthcare workers. I remember planning my hospital's vaccine rollout, painfully knowing that the vaccine probably wouldn't help me very much. I learned from my new dermatologist that relapse was likely after a single round of rituximab. So even though I was mostly recovered, I had another round a year later, this time at the peak of the Omicron wave. That was more bad timing, and like many immunocompromised people, I've been living like a hermit throughout the pandemic. I also receive monthly IVIG, which I am hopeful will help with long-term remission. It is a major time commitment, with each round taking about 16 hours per week. I'm fortunate to be able to work from home during the infusions, but I still end up missing important meetings, and it's difficult to be fully productive with an IV running. Ironically, given how expensive and time-consuming IVIG is, the most stressful part hasn't been about insurance issues or getting off work. It's actually been about scheduling reliable home health nurses during the Great Resignation and getting the right dose of IVIG during the supply chain crisis. As it stands, steroids are the current first-line treatment for pemphigus. They're fast, cheap, and effective, but patients can't take high-dose steroids for a long time. I can't emphasize enough how miserable that is. Instead, we need new steroid-sparing treatments like rituximab. However, both prednisone and rituximab have a blanket immunosuppressive effect that complicates life, especially during a pandemic. Instead, pemphigus patients need more precise therapy options, ones that are less immunosuppressant and have a better side effect profile than the current crop of shotgun-like immunosuppressants. I have a great doctor in Chicago now who, in his words, was willing to throw the kitchen sink at my pemphigus. However, I wish he had more targeted and effective therapies at his disposal. I wish the current therapies had less terrible side effects, and for all the expensive therapies I've had, I wish I had a better chance for long-term remission and even a cure. So thank you for letting me address you today. And Mark and Becky and Amethyst, you guys did a fantastic job here today.
Robert, thank you so much. And I'll tell you what, I didn't mean to steal your thunder, but you said it better than any than I could have ever said it, the way you phrased that. And I'm sure that's going to make it into the Voice of the Patient report for sure. So, but thank you so much. I also really appreciated, your comment on just how much the disease, how much of a toll it put on your physical and mental health. I mean, I think that's something that does not get emphasized enough. And I hope, obviously, through this meeting today, that message is coming through thanks to your help. So thanks again for the great comments you provided.
Yeah.
And our last speaker today is Scott Taub, and Scott Taub is from Illinois. So Scott, take it away.
All right. Hopefully everybody can hear me. Thank you everyone for attending the meeting and listening to all of this feedback. I'm a patient with Pemphigus vulgaris. I'm also a peer coach for the IPPF. In that role, I provide information to and share experiences with others who have Pemphigus or Pemphigoid to help coach them along their journey to being treated. Like most Pemphigus patients, my treatment started with prednisone. I was relieved to finally get treatment after a diagnosis on doctor number 11. But my doctors spent a lot of time making sure I understood that while prednisone would help, it was far from an ideal solution. They warned me I'd likely experience side effects ranging from insomnia to irritability to weight gain, that with each passing month, the risk of serious side effects, as if those other ones weren't serious, would grow. Side effects like loss of bone density, diabetes, organ failure. They warned me that when it was time to stop taking prednisone, I'd have to taper off of it very slowly to avoid a flare or a dangerous adrenal crisis. And then I'd have more side effects during the tapering process: joint pain, fatigue, inability to focus. At that point, my PV symptoms were so significant that I didn't really care what the side effects were going to be. It had to be better than what I was experiencing. And that's what most of us deal with. We use prednisone because it's the only drug we have that begins to work quickly and that works for most patients. But as soon as it starts to work, we begin to look for the drug that will allow us to get off of prednisone before those serious side effects come. I took Cellcept for a year, but every time I tried to reduce my prednisone dosage, I flared up. After that, I switched to Imuran, which finally allowed me, after another 18 months, to get off of prednisone. Why did it take so long? Because Cellcept and Imuran, as well as any of the other drugs I might have tried, don't work for everybody, and they can take a long time to work when they do. I was lucky back in 2013 through 15 that it only took 2 immunosuppressants before I found the one that worked. And I was lucky that neither Cellcept nor Imuran gave me bad side effects. Others cannot last long enough on those drugs to even find out whether they'll work. I'm in remission now and off all medication, and my path to remission is pretty close to a best case scenario for somebody diagnosed with Pemphigus. Even still, I suffered with symptoms of PV for over 3 years before going into remission, on prednisone the whole time, while searching for a drug that could keep my disease in check with less side effects. Don't get me wrong, the treatments we have are miracles, and I know that without them, there's a good chance I wouldn't be around today. And recent advances like rituximab, but even for those that get to remission, there's usually a long period of poor quality of life and reduced productivity. Many of our patients cannot work or care for their children or family during that time. We know there isn't likely to be a cure for an awful long time, but what we all hope for is drugs that can do any of 3 things, in my view, better than the current treatments. First, drugs with less side effects, so that the side effects don't undo so much of the benefit of the drugs. Prednisone side effects are so significant that I know of multiple patients, and you've heard from some today, that refuse to take it anymore and endure the discomfort of the disease while looking for something else that'll work. But it's not just prednisone that has side effects that cause problems. Imuran carries a risk of liver problems, so we need periodic blood tests to monitor. IVIG causes headaches so bad that some people wind up in the emergency room. Even topical steroids can be dangerous as they lead to skin that easily bruises and tears. And every immunosuppressant carries with it the increased chance of infection. For many of us, that isn't a temporary thing, as a lot of our patients cannot stop taking the immunosuppressants without a flare of the disease. COVID only increased the significance of this concern and this problem. In fact, I'm getting over a bout of COVID right now, and I was very glad that I was not on any immunosuppressants when the pandemic hit. Second, we need drugs that work, or if they're not going to, don't work faster, so that we don't have to waste a year on a treatment that isn't going to do it for us. Like I said, I had close to a best case scenario, and it still took 3 years till I got to remission. And third, we need drugs that work for a greater proportion of people, so we can try those drugs first. As of now, it's kind of guesswork as to what might work for a different patient. Drugs that work for a higher percentage of people would mean a much shorter time of poor quality of life for more patients. I would close by saying even small improvements in any of these 3 areas would make a huge difference to many of our patients. Thank you for listening and for your attention today.
Scott, thank you so much. Again, I couldn't have said that better, so I really appreciate you summing things up for us. And I want to thank all of you for all of your comments today. You know, your stories and comments certainly show firsthand the physical and psychological impacts of the disease and its symptoms. They also highlighted all of your struggles with comorbidities, as well as the emotional and you know, the burdens of the disease, the management, prognosis, as well as the social impacts and effects on relationships, you know, clearly have had, you know, profound effects on all of you. So thank you. Before we share our last video recorded public comments regarding available treatments for the disease, their side effects and how to improve them, let's launch the last poll of the day. Thank you all so much for taking time to engage in these polls. It's going to be extremely helpful. And this poll actually consists of 5 questions for you. These important treatment questions will help us really understand and also share with the FDA how your disease has affected your overall quality of life. Becky, you have some comments for us as we begin to close the meeting?
Absolutely. Thank you all for your time and your effort in being here today and your help with all the polling questions. These important treatment and quality of life questions that you answer today will provide a better understanding of these diseases and allow us to share with the FDA and drug developers how your diseases affected you and your families. We appreciate the time that you spent helping us gain insight into understanding and your willingness to share your experiences with us and the FDA. Please know that your answers to these questions are important and will be shared as part of the Voice of the Patient report that we will be writing and sharing with the FDA, which will be used for the FDA when new treatments are submitted for approval. We've heard a lot of stories today, and I encourage everybody to be kind to themselves today, as today was not an easy day for those who shared their stories and for those who were listening. Thank you.
The IPPF had an ask. Talk about your disease symptoms and treatments and how they impact your daily life. My name is Jamie Michelson from Detroit, Michigan. Yes, Motown. But I'm not going to sing. I can't sing very well. In fact, last year I couldn't have made this video. I had hoarseness and difficulty talking, as well as challenges drinking, eating, and sleeping. Basic daily life. My story starts at a regular 6-month dental checkup. I was having intermittent sores develop in my mouth. One would resolve and a new one would develop. My journey took me from dentist to internist, back to dentist, to an ENT, to a GI specialist in upper GI, to an oral surgeon, back to my internist, to a second ENT, to the ICU, in a 3-day hospital stay. In terms of medication, I started with my own treatment of warm salt water and using Anbesol on sore spots, before professionals added a paroxysmal mouth rinse, omeprazole, a mouth rinse of dexamethasone, or erythronidal rinse, viscous lidocaine so I could try to eat without discomfort. All these medications were intended to provide symptom relief. Nothing worked that well and none addressed the underlying condition. I was down 15 pounds. Besides struggling physically, I was struggling emotionally to stay upbeat. When the ENT biopsied the inside of my lower lip, a very painful step, that sample, along with specific blood tests, finally resulted in a diagnosis of Pemphigus vulgaris, nearly 10 months after initial symptoms. It's my understanding that, compared to many PV patients, diagnosis and treatment in a 10-month span makes me one of the fortunate ones. My dermatologist referred me to a nationally recognized specialist in autoimmune skin diseases who got me started on prednisone, and after 10 forgettable months of true struggle and runaround, with additional timing moves around COVID vaccinations, in for a series of Rituxan infusions. It worked. I'm so very happy to report that the combination of the steroids and Rituxans day 1, day 15, and again 6 months later has put me in near remission. I have few sores, no full flare-ups, and with appropriate immunocompromised caution, am living normally. The bottom line, or I should say bottom lip, is that with pemphigus, daily life is pemphigus, thinking about and working around it if possible. With effective treatments, daily life becomes normal life, sometimes boring, mundane, normal life. There's a quote, "Give thanks for the normal day." Believe me, I do. And I thank all of you for your efforts and support.
Hello, my name is Isabel, and I was diagnosed with mucous membrane pemphigoid in 1995, but it started a good 2 to 3 years before that. The very important feature of MMP, in my view, is that it leaves scars, and living with the damage done by the scarring is life-changing. It started in my mouth and nose, and I spent 2 years being treated and treating myself with diet, herbals, homeopathy, etc., for what had been diagnosed as severe allergy, which was like having a very heavy head cold. It was, as I was starting a new, very demanding job, it was a very great convenience. In 1995, after several possible triggers knocked me into a huge flare, affecting all the skin on my hands and feet, I was diagnosed by biopsy with MMP. I spent 2 weeks in hospital on 80 milligrams of prednisolone and morphine to manage the pain. The blisters on under my toenails were particularly excruciating. By the time we knew what it was, the inside of my nose had fused together and the lining was irreparably damaged. After over 20 surgical interventions, I was left with no septum and no sense of smell, and blocked eustachian tubes, resulting in deafness, for which I wear a hearing aid. The MMP continued to rampage through my body, affecting every orifice: nose, mouth, throat, trachea, eyes, rectum, genitals. Are there any more holes, I asked myself. All except my mouth were left with sticky scars that caused stenosis. No drugs seem to have any impact on the disease. I've tried them all but rituximab, and I'm now celebrating 28 years on prednisolone, currently at 8 milligrams per day, although I do vary it depending on my symptoms, with the accompanying drugs and supplements that manage the side effects of it. I did wonder if I was in remission at one point, with only occasional flares, until 3 years ago a large blister blew up and blocked my epiglottis, and I spent 3 days intubated and sedated in intensive care. Thank goodness they didn't perform a tracheotomy or do any other intervention to make the problem worse. I now wear an emergency bracelet and live in fear of a repeat. I can live with the constant nose drips and oozes. I've had my nose picked by many experts over the years. The regular lung infection caused by the mucus also causes a problem. I have scarred salivary glands, which generate lots of saliva or none, causing teeth problems. I use an eye bag and a steam inhaler every day to counteract the effects, particularly the frequent blepharitis. I can pluck out most of my ingrowing eyelashes myself, fortunately, but they can be extremely painful and irritating until they're plucked. But by far the worst effect was the 15 life-changing years without a voice. I'm a pretty robust person and can easily soldier on even without being fully functioning. But the isolation and social and work challenges created by not being able to speak were hard to bear, and I did contemplate suicide on many occasions. Miraculously, my voice returned 2 years ago, almost concurrent with the start of lockdown. And just think of the horror of being locked down without a voice to speak to anyone. That would be true isolation. Anyway, I'd like to thank you for listening to my story.
My name is Lou Della Penna, and I have bullous pemphigoid, BP. It all started in April of 2021 when I was 78 years old after having Moderna COVID vaccine shots in January of 2021. I first presented with a rash on my chest, and then blisters formed over my entire body, including in my mouth and nose. I visited two different dermatologists, a head and neck oncologist, rheumatologist, and my primary care physician. After a few biopsies, I was diagnosed with BP. My initial prescribed treatment was of high doses of prednisone along with clobetasol and magic mouthwash, and they were not helping. I was deteriorating rapidly. My family and close friends thought I wasn't going to make it. I was losing weight. I was having great trouble taking care of myself. Eventually, I was prescribed with rituximab and was fast-tracked to have 2 infusions. After the infusions, I was able to see Dr. Amy Payne, a top dermatologist at the University of Pennsylvania Hospital. She put me on a special regimen, and when combined with infusions, I am in remission. BP impacted me and my family both greatly, both physically and mentally. I couldn't exercise or walk, even though prior to incurring BP, I was walking 2 to 3 miles a day. I had to go on a soft diet and couldn't sleep. My clothes and sheets were destroyed by blood blisters bursting. The prednisone was incredibly debilitating, and I fell 3 times, and one fall I incurred a compression fractures in my back. I experienced dizziness and vertigo on a daily basis. I was hospitalized for a GI bleed after taking Eliquis because I developed a blood clot and couldn't walk. Remember, I was walking every day. I was immunocompromised from the infusions, which were very frightening during the pandemic. My real concern for other BP patients is the length of time to diagnose and receive the appropriate treatment. Having been on 2 hospital boards at the time of my diagnosis, I had the medical contacts to quickly and effectively allow me to navigate the system, as well as the financial means to pay any doctor's visits, medications, and treatments that were not covered my health expenses, as well as other expenses. BP is an insidious disease that begs the attention of the pharmaceutical and biopharmaceutical industries. We need your help. Thank you.
Hi, my name is Odette, and I am a Pemphigus vulgaris patient. I was diagnosed in 1990. I was 19 years old, and I've had pemphigus for about 33 years. One of the treatments that I've been on since being diagnosed is prednisone. I've been on as high as 160 milligrams to as low as 2.5 milligrams. And currently I'm on 10 milligrams. This form of treatment for my condition, weight gain, I have bone loss. Being in my 50s, I am concerned about this treatment that I'm on as I get older, and I worry about the quality of life I will have as I approach, my senior years, and when I go into retirement, what kind of life will I have to enjoy my life in retirement? just the thought of having some kind of other treatments to treat my condition, I am so hopeful to be put into remission one day. The studies that some of these pharmaceutical companies do, the research that's being done for, substitute treatments that may work on other patients' conditions that could probably work for a pemphigus vulgaris patient to put me into remission, I think is greatly needed to give, in my mind, give me a better quality of life, of a drug that maybe I can use. That I know all drugs have side effects, but being on prednisone for as long as I have been, and the side effects that, I'm currently going through with taking this drug. Yes, it has kept me alive, thus far. But to continue to take it and just watch myself decline, there's the weight gain. I have, the hair loss, which to me, it takes away from my quality of life, of the things that I have to do just to make myself look presentable, to go out and to go to work every day. As I get older, I feel my energy depleting from me. So that's kind of my story in a nutshell, that I do look forward to treatments that can help me with my condition and take me off of the prednisone.
Wow. It's quite a day. And I want to thank all of you who are still with us as we wrap this up. Now, before we conclude our meeting, I want to thank every person who shared their story today. Whether in person or on video, it takes immense courage to, it takes immense courage to publicly relive some of the hardest times of your lives. Though every person's journey is unique, today your voice was not only your own. Today, you spoke for the thousands and thousands of people living with pemphigus or pemphigoid. Your bravery is the true inspiration here. Thank you for sharing it with us. I'd also like to thank our coalition of meeting organizers, PemFriends from the UK, the Association Pemphigus Pemphigoid France, the Pemphigus Pemphigoid Friends Association from Japan, and the IPPF staff who pulled it all together. Finally, thank you to our sponsors for making today possible, argenx, AstraZeneca, Janssen, and the Every Life Foundation for Rare Diseases. So it has been an emotional day, and I'm sure there are many people listening in who did not get the chance to speak. If you want to share your story or comments about today's meeting, you can email pfdd@pemphigus.org. That's pfdd@pemphigus.org. Over the next several months, we will be preparing a Voice of the Patient report that will not only summarize this meeting, but will also publish additional written comments we receive. This report will be shared with the FDA. So what did we learn today? We learned that both pemphigus and pemphigoid can be severe life-threatening diseases that cause significant burden on the day-to-day lives of patients. It's evident that there's a need for treatments that address both the long-term and short-term effects of these diseases. The current treatment landscape is sparse, with only corticosteroids and rituximab approved for pemphigus vulgaris, and no approved therapies for pemphigoid. This creates access issues for many patients, as drugs must be prescribed off-label. Perhaps even more significant are the challenges faced by patients in balancing the burden of disease versus the burden of therapies, as the side effects from chronic use of steroids often have a debilitating effect on patients. This community needs therapies that control their disease without serious side effects. To meet this need, clinical trials should utilize appropriate endpoints that accurately reflect those issues that are most important to patients. Along with the validated measures, patient experiences can help inform researchers about the physical and psychological impacts of these conditions to help guide investigations into new treatments. As new therapies are developed and we learn more about these diseases, it is also important to refine the meaning of words like remission so that they accurately reflect the lived realities of patients. Due to the side effects of steroids, minimal therapy is often the primary goal in the minds of patients, with the long-term goal of complete remission being secondary. Because steroids have such profound effects on people's daily lives, therapies that are steroid sparing are of great interest to patients. In other words, new therapies don't have to be perfect as long as they provide meaningful benefit to a person's quality of life. Additionally, since we already have sensitive, validated assessment tools that measure this, any new tool must include the patient's perspective into what is most important to them. It is our hope that today's meeting not only clarified the unmet needs of pemphigus and pemphigoid patients, but also highlighted the importance of the patient voice in the drug development process. It's imperative that regulators, industry, researchers, clinicians, and advocacy groups hear directly and continually from those who are most impacted by their decisions, the people living with these diseases. Though the challenges are many, there's more reason than ever to be optimistic about the future treatment landscape for pemphigus and pemphigoid. At the IPPF, we've observed a steady increase in research in recent years, with more studies and trials in the pipeline. And though today's meeting is coming to an end, this can really be the beginning of future collaboration under a common goal: to improve the quality of life for all people affected by pemphigus and pemphigoid. This concludes our meeting. Thank you for joining us today.